Okay, so this is an approach to a swollen, painful knee, and this is mainly meant for medical students. So the main thing, the main question, the main definition that we need to understand is what is a swollen knee, and it's a red flag. It means an effusion or pus or blood in the knee or synovitis. So either there's fluid in the knee or there's synovitis in the knee. The fluid, there are two tests that are very good to pick it up clinically. The one is a ballottement test where the patella is pressed onto the femoral condyle, and the patella normally sits right on the femoral condyle. With an effusion, it doesn't. It actually lifts off the femoral condyle, and you can push it back onto it, and you can actually feel it. The swipe test is another test where you can see fluid. You can take your hand on the medial gutter and you wipe the fluid from the medial gutter through the pouch that's above the patella, so superior to the patella, and you wipe it to the lateral gutter, and then when you press on the lateral part of the knee, you can actually see the fluid reaccumulating on the medial part of the knee. The main approach to this is history, examination, potentially an aspiration if you don't have x-rays readily available, and then x-rays. And that will give you about 90% of all diagnoses, underlying diagnosis of a swollen painful knee. In the history, the main question to ask is, did you have trauma? Did you have an injury or not? Because that groups those patients into two main groups, and it makes it a lot easier to have a look at them later on. In case of trauma, the main question is there or was there immediate swelling in the knee? And that means mainly, was there blood in the knee? Blood accumulates very quickly after the injury, and it usually means that there was either ligament tear, a fracture, or a patellar dislocation. So those three things usually cause immediate swelling of the knee. If the knee wasn't immediately swollen, if there wasn't a loud pop heard, or the patient continued to play and only felt knee swelling later on, even the next day, it's often either extra-articular or it's a meniscal tear. So let's look at the meniscus. The meniscus has blood supply that is mainly around the periphery of the meniscus, and it doesn't have a lot of blood supply on the inner third of the meniscus. So the rim of the meniscus is well perfused, but then unfortunately not the inner part of the meniscus, and that means that it doesn't heal properly because you need blood and blood clots to heal. And on the right you can see the main function of the meniscus is to distribute weight or force that goes through the femur into the tibia. And if the meniscus isn't there, then there's point loading, and that makes the cartilage, that damages the cartilage over time. So no meniscus basically means accelerated wear and early arthritis. So let's go to a case. This was a patient that was referred to us from the spine team. The patient was born 1936, and she danced. This patient danced and had an injury 4 months ago, and the knee was badly swollen and painful, and we should please evaluate this patient. So the best way to pick up meniscal pain is meniscus symptoms is pain, effusion, if there's catching or locking, and if there's sensation of giving way or decreased range of motion. And the best way to pick it up clinically is to actually elicit joint pain. So patients with joint pain is the best way, or the most accurate way to look at meniscus tears, or to detect meniscus tears clinically. But it's not a very accurate way overall. It's still between 60 and 80% of clinicians are able to pick up meniscal tears with this test in larger studies. The most sensitive way to diagnose meniscal tears is an MRI scan, but it's also the most expensive way, and therefore we shouldn't always just do an MRI scan on all patients where we think that the meniscus is torn. The reason for it is that degenerative meniscus tears, the best way to treat them is actually conservative management. And this is a study that was done in 2013, and it was published in the New England Journal of Medicine. You can see two lines here on the graphs on the right, and those lines are very close to each other, and those are all patient-reported outcome scores. And the two lines represent a group. Each line represents a group. The one group had meniscal meniscectomies done, and the other group just had a sham surgery done. It means they did an incision, they didn't do meniscectomy, and they didn't tell the patients what they did. So both of those groups did very similar. And since that study, we were a lot more conservative with treatment of degenerative meniscus tears. It doesn't mean that they shouldn't be operated, but it means that we should be very, very conservative when we make a decision to operate these patients. The main indication is when there's mechanical problems like locking or clicking, and that's sore and it doesn't go away. Then it's worth to do an operation for these patients. So another case. Now this is where we have to save the meniscus. It's a 25-year-old rugby player. He's young and he's active, and is 1 month after his injury, and the knee is still swollen and painful. You can see he's got a meniscus that's extruded out of the joint. It looks like the root of the meniscus is torn, so it's lost its function, and there's a lot of edema in the bone already, and that basically already shows you what the long-term effect of this is. The meniscus can't pad the joint anymore, can't distribute the weight anymore, and it just causes damage over time. And those are the patients we need to operate early to be able to protect the knee joint and prevent arthritis later on. So let's look at the ACL injury. The ACL is a ligament that's inside the knee, and it is preventing, or it stabilizes the knee so that the tibia can't move anterior or forward in relation to the femur. It doesn't have a lot of blood supply. You can see that the vessels here on this image, they kind of spare the ACL, and that also means that it doesn't generate a nice clot that can heal nicely when it tears. The injury mechanism, and this is Michael Owen's injury in 2006, where he had a foot planted on the ground, and then the body rotated over that fixed foot. So it's a twisting injury. It's usually non-contact, and that gives you an ACL, ACL tear. Okay, so let's look at the examination of an ACL, and those are two tests that are important when you assess the ACL. The one is on the left here. The one is a PCL laxity test. By pushing the tibia backwards as the posterior draw, you can see that the PCL is intact. Whereas on the right here, you can see that the PCL isn't intact. I can actually push the tibia backwards in relation to the femur. Whereas the ACL is torn in both knees. So the main take home here is that you must always test the PCL as well, not just the ACL. So there should be an anterior and a posterior draw that you do in these knees. Another test is the pivot shift test, and it basically you can see that the ITB that you can follow now sliding over the femoral condyle here, that ITB reduces the tibia posteriorly in flexion. In extension, the knee is anterior subluxed, and in flexion it reduces to where it's supposed to be, and that's a pivot shift test. But it's not a test that should be done in an awake patient. So it's a test that is mainly done before we do an operation. An X-ray is useful if you see a little flake like this on that is with the arrow says A. That is a flake. It's an avulsion fracture of the capsule, and it's called also a second fracture. Now, that doesn't mean that it's just a small little fracture. It actually means that it's the tip of the iceberg. If the capsule can tear off the tibia, it usually means that there's a bigger ligamentous injury underneath or within the joint. What's marked as B is an avulsion of the eminence, and that's usually where the ACL inserts, and it can show you that there's an ACL tear. But these fractures, these avulsion fractures, are not always visible. And this is the management of a ACL. Mainly, the decision on whether we should operate or not is based on the age of the patient, how active the patient is, and how much that knee translates compared to the other side, or how lax that knee is compared to the other side. So in very young and active patients with a knee that has a very severe laxity, it's worth to operate. Whereas in an older patient that is not very active and has a fairly stable knee and can function, it's not necessary to operate. And the videos here show how an ACL looks like in an arthroscopy when it's torn or partially torn. That's the top video, and on the bottom you could see how we started to introduce a graft to basically reconstruct the ACL. So, what is the differentiation clinically between a fracture and an ACL? And it's so difficult in a cold fracture and a ligament to differentiate between that and a ligamentous tear, because patients are very, very painful acutely when they present with this injury. And a nice way, especially in a fracture that's difficult to see on X-ray, which can be the case, is to do an arthrocentesis. That means to draw fluid from the knee. And what you can see in an ACL injury or patellar dislocation is blood. So the syringe will draw blood. And in a fracture, you can actually see little fat globules that swim on top of the blood, and that can point towards a fracture. In an X-ray, you can obviously have a fracture that is easy to see, but in certain areas or in certain age groups, it's sometimes very difficult to see a fracture. And a trick to be able to unmask some of the to unmask a fracture is to turn the patient horizontal and then take an X-ray from lateral, and you will be able to see a fluid film, so a line that goes just underneath the patella, that basically shows you blood below and fat above. In all of these injuries, especially when the fracture is displaced, it usually means that the patient needs an operation to realign the joint. Otherwise, there can be severe arthritis at a later stage that we want to prevent. Okay, so the next injury that can give an immediate swelling in the knee is a patellar instability or patellar dislocation. The patella has got the thickest cartilage in the body, and it's a very strong bone, and it's actually suspended by the quadriceps and the patellar tendon. And it's held in the middle of the knee by a ligament called the medial patellofemoral ligament. And that ligament keeps the patella from dislocating lateral. So this is a patient where you can see that the patella is dislocated lateral. And the key questions to ask these patients is, was it a high energy or a low energy? Did you have, if the knee was reduced, who reduced this knee? Did it reduce on its own, or did someone reduce it for you? And then also, is there any family history of a patellar instability or any systematic problems? When it happens recurrently, so the patella dislocates not just traumatically, but it happens very often to the patient, then we need to understand what the age was at onset, if it is unilateral, bilateral, and how many episodes of this dislocation has happened before, what the mechanism was, is there pain associated with it, and what are the expectations from the patient. So the clinical exams for these patients is mainly an effusion of pain, and the kneecap often does not move up and down, but has a J sign. That means it moves more lateral in extension, and as soon as the knee flexes, the patella basically moves back into the trochlea, and then becomes more aligned over the knee. Another very good indicator for a patellar dislocation or recurrent patellar problems is an apprehension sign. That means when you take the patella and you move it lateral, the patient is apprehensive or painful. A lot of these patients are also hyperlax, and it's important to understand or exclude hyperlaxity in these patients. The treatment for most acute patellar dislocations after they've been reduced is conservative. About half of the patients will heal and will not have recurrent patellar dislocations. In recurrent patellar dislocations, the go-to treatment is ligament reconstruction with a hamstring tendon, for example, where we try to reconstruct the medial patellofemoral ligament. The acute reduction should be done under conscious sedation, and here the knee is then extended and the patella is pushed medially, and after that the patient is best placed into a brace, and then for about 2 weeks, and should have early physiotherapy to make sure that the knee doesn't get stiff. Okay, so let's look at a patient that comes to you and says, I've got a swollen, painful knee, but I didn't have trauma. What would be the next good question to ask here? And what helps you to put these patients further, or subgroup these patients further, is to ask how many joints are painful and how many times was this joint painful. So was it a single joint in a single episode, or multiple joints and multiple episodes? In a single joint and in a single episode, the most important condition to think about is septic arthritis. When there is multiple joints involved and multiple episodes or recurrent problems, then the two most common conditions are either osteoarthritis or inflammatory arthritis. In septic arthritis, it's usually an acute onset, and we have to exclude immunocompromise or think about IV drug abuse. The joints are usually red, warm, tender, and they've got a decreased range of motion. What you can do here now is to take fluid and send that fluid away to the lab. And what would you send this fluid away for? What would you look for in this fluid? Okay, so you would take a gram stain, you would request a white blood cell count, and that basically anything above 50,000 is indicative of septic arthritis, or is a confirmed septic arthritis. You would ask for bacterial culture, and that will also give you sensitivities for antibiotic treatment. But Never forget about tuberculosis investigations. So there you can ask for TB culture and a PCR test called Gene Expert Ultra. And also crystals. There is always a potential for this being a crystalloid inflammatory arthritis. So in the inflammatory arthritis, the difference between inflammatory arthritis and osteoarthritis will come just now, but in most of these conditions there's a long-standing history, there's chronic medications that these patients are taking, and there's usually extra-articular pathology. But mainly in rheumatoid arthritis, it affects small joints, it's symmetric, and it has synovitis. When you look at the X-ray, you can see that there is joint space narrowing, and also there is osteopenia. The bone looks like it's washed out. It doesn't have a lot of osteophytes, and it's got concentric joint space narrowing. That's the main features of rheumatoid arthritis on X-ray. Whereas when you look at the osteoarthritis, you can see there's eccentric joint space narrowing. On this X-ray, the medial side is a lot more narrow or worn down than the lateral side. You can see osteophytes, there's some cysts, and there's subchondral sclerosis. And those are the main 4 features that you can see on a knee, an X-ray of the knee that's got osteoarthritis. Just remember there are other inflammatory conditions that are associated with arthritis. We're not going to talk about them in this presentation. Gout is another important condition. It can live in between a single joint, single episode, and multiple joints, multiple episodes. The main feature of gout is gout trophi. And these trophies are usually in the periphery or peripheral joints where the areas are not very well perfused, especially on the fingers or toes. They often look like toothpaste when there's surgery done, and under the microscope we can see the characteristic crystals. So the main treatment in an acute attack is colchicine, and in a chronic gout attack or a chronic gout patient, allopurinol is given. Tuberculosis is another very important condition that needs to be in the back of our minds always in South Africa. What is characteristic for aspirations of the joint is that it is not clear, the fluid, but it's also not frank pus, it's straw-colored fluid. That fluid can be sent away or must be sent away for culture, for histology, and to do a PCR test. These patients should be referred to an orthopedic surgeon so that we can start with a treatment and monitor them and monitor the response to the treatment. Often they don't need surgery for the condition itself, but they need surgery to diagnose TB and to also exclude a resistance of tuberculosis to certain drugs. So it's important for us to know about these patients and to manage them further. And this is what we spoke about. This is the approach in terms of the history that we'll be able to group these patients into various subcategories, and from there you can then basically diagnose further with a good examination and an X-ray and an arthrocentesis. Thank you very much for listening.